So I have decided to split the Medicaid program into two separate sessions. I will go over the agenda. So today what we're going to do is primarily focus on those core eligibility rules for most Medicaid programs in Illinois, and kind of talk a little bit about how the state determines what a household is, whose income counts for Medicaid eligibility. Those of you who were with us in March, where we kind of reviewed SNAP and cash assistance programs, kind of just keep those income counting rules to the side, because Medicaid is a completely different beast when it comes to households and income. So we'll kind of review all of that core eligibility. We'll also talk about the managed care program a little bit in today's session. I also want to review some of the special Medicaid programs that are out there, things like health benefits for workers with disabilities, or HBWD. I've also heard people call it HIBWID. So depending what you hear out in the provider community, you may hear that called different things. Also going to talk a little bit about the emergency Medicaid program for non-citizens, as well as VTTC, which is Victims of Trafficking, Torture, and Other Serious Crime, a program for that. And I think we touched on that in March as well, but it's worth repeating. And not long after we met in March, they changed the email address for the unit handling those applications. So kind of a bit to talk about there. And then I decided, I was debating whether or not to save this for next week or just how the flow of information would go, but I have included some of the information about what HFS, or Healthcare and Family Services, has done with regards to program changes, with regards to the impact of COVID-19 and some of those flexibilities that they are implementing for the time being. So we can talk a little bit about that. So it is a full agenda. Not quite sure if it will take the full 2 hours or not. We will see, right? So I will go ahead and get started. And just let me double check. Yes, okay, we are ready to go. So in Illinois, Medicaid is known by many different names in terms of the actual programs. And those programs are really dependent on the population that that particular program is serving. Medicaid overall is a state and federal partnership. How that works is that the federal government, CMS, or Center for Medicaid and Medicare Services, they really write the administrative rules, kind of structure the entire Medicaid program, and fund states with regards to Medicaid. But it's kind of a complicated formula when it comes to funding, and that's really not the purpose of today's training. Yet I find it important to understand, because some of these programs, it's a state-federal partnership, so the feds give us a match to cover the population that needs Medicaid. And the split of that match in terms of how much the federal government supports Medicaid in Illinois versus how much the state of Illinois supports changes depending on the program. And so you'll hear me sometimes talk about state-based funding or state-based coverage. Things like the VTTC program is completely state-funded. Parts of All Kids, not all of it, but parts of All Kids are also completely state-funded. And so it's helpful to know behind the scenes that that's going on, especially when we are talking about serving immigrant clients and talking about who is eligible in Illinois, and if they move to another state, who may not be. So just a little context there. So in Illinois, these are the different names. You know, some people just call it Medicaid, but you know, if you're serving children under 19, they are probably enrolled in the All Kids program. Family care and ACA Adult Medicaid, this is for adults 19 to 64. The difference between family care and ACA Adult is simply that folks eligible for family care have children in the home that are part of their household, but the income limits are the same for both of those adult programs. Moms and Babies is specifically for pregnant women and newborns up to age 1. And then the AABD Medicaid program, or Aid to the Aged, Blind, Disabled. This is really targeted towards persons either who are disabled and receiving Social Security benefits, or age 65 plus, or blind. And the thing with AABD Medicaid is that they're also usually on Medicare. We will revisit this population in a little more detail next week on July 9th when we do the Medicaid Part 2. And this just breaks it down a little bit further in terms of specific requirements within each of these programs. And you should have received an email from me last evening. I'd also attached the documents to the calendar invite, but I sent out an updated FPL income chart. So you should have that in your inbox. So just to review quickly, ACA adult, family care, you can see they must be a citizen or a qualified non-citizen, and I will review these citizenship requirements again in a moment. With all of the Medicaid programs in Illinois, you must be an Illinois resident. And let me just remind everyone that what Illinois residency means, it doesn't mean that they have to have been here, living here for a certain period of time. They just have to establish residence, intend to reside in Illinois, and be able to prove that, whether that's through a lease or a bill being sent to their address. If they're homeless, the state is supposed to accept their statement of homelessness, and then if they're engaged with a social services agency, that can sometimes be used to support that residency statement. And then income at or below 138% FPL. And I do not have the income limits in front of me at the moment because I'm home and not at the office today and left it on my desk the other day. But anyway, you can see what 138% FPL translates to on that sheet. AABD, again, aid to the aged, blind, disabled, also has that citizenship or qualified immigrant status requirement. In this case, the income is at or below 100% FPL. Now with the AABD program, there is a program for the medically needy, and if people have very high medical expenses and their income is over this 100% income limit, the state may enroll them in the Spend Down program. We will get into more detail about Spend Down next week, so stay tuned for that. But the short of it is that if they're over income and in the AABD program, they can use medical expenses to bring down the amount of their countable income to a point where the state will activate Medicaid. It's like a deductible, except it has to be met every month. So again, we will revisit that next week. So I would just ask to kind of hold questions around Spend Down to next week, because I know there's always questions. AABD does have an asset limit. So for a single person, they are limited to $2,000 in assets or resources. There are things that the state doesn't count, like the home that they live in, one car, and some other things, but there are asset limits. So if they, let's say, live in a home but also have a rental property, that rental property would count as an asset. If they have significant investments or savings past the $2,000 as a single person, anything beyond that $2,000 would count as an asset. For moms and babies, income's a little higher than what you'll see for the ACA adult and family care coverage. So we often see many women who may not be eligible for those programs, but once they become pregnant, they may become eligible for moms and babies. There is currently no immigration status requirement when it comes to the moms and babies program. So undocumented pregnant women are welcome to apply for this program. Other immigrants who maybe are LPRs, but not for that 5 years yet, if they're pregnant, again, may be able to apply for moms and babies. And then this program lasts for 60 days postpartum, though they are working on rules to extend that for a year. There's been a lot of research and documentation done just about infant and maternal mortality and the rates among women in Illinois, and especially among women of color. And so the benefit of extending moms and babies coverage for an entire year to go beyond that for 60 days, we know would help with health outcomes. So stay tuned as that kind of rolls out more officially, we can get more information to folks. And then all kids. It says here age 1 through 18, and that is through the entire year of 18. Once the person turns 19, they'll have to go through the redetermination process. Well, let me first say this, with all kids, again, no immigration status requirements. So undocumented children are able to access Medicaid through the All Kids program. That is state money going to cover that population. And then at 19, when they go through the redetermination process, if the person doesn't have a qualified immigration status, they will lose the Medicaid. The All Kids will end and they are not eligible for adult Medicaid unless it's a pregnant woman. Otherwise, same thing with the even citizens who are on All Kids. You can see the income limits listed here. It's a little higher, you know, all the way up to 318% FPL. And if you want to kind of know what that monthly figure is, again, I would refer you to the FPL income chart. But if as an adult, as at 19, if they are not at those 138% FPL income limits, All Kids would end. And we'll talk a little bit about redetermination. I think that's next week too. And so we can talk a little bit more about kind of that transition at age 19 and what happens if there are specific questions. I do like to point out with All Kids, there are 4 levels in terms of income limits, all listed on that chart. And when it's All Kids level 1 and 2, you'll note this third bullet here that the child must be uninsured for 3 or more months. That applies if the family has had no health insurance at all. There might be this waiting period. That's probably not the best way to describe it. But I do just want to say, if someone, let's say a family had health insurance, and maybe it was through a job, and then especially in these recent weeks and months, right, maybe the family lost job and lost access to health coverage, because that was kind of that special event, they would not have this 3-month waiting period, even if they had been at this income level. And really it is just it's a rule really for the higher income levels. All Kids share, and the regular All Kids, there is no uninsurance requirement. And here's that chart that I mentioned. So we can see for ACA adults currently, a single adult has to earn at or below the gross monthly income of $1,467. So they just published this policy. I think they finally put it up at the end of March, April 1, but technically these income limits should have been in effect since January. So just because the state didn't publish the policy right away doesn't mean that they weren't already applying it this way. If you go to the far left, AABD, and I'm not sure if you can see my cursor on your screen, but that's where we see the single person at $1,063 per month. And then moms and babies, notice there is no household of 1 for the moms and babies program. That's because with Medicaid, they will count that fetus or that unborn child as a household member. And so if it's a single woman who is pregnant, her income limit is at $3,060. I think I heard once that about 50% of births in Illinois had moms and babies coverage. So a lot of women do move on to Medicaid. And remember, with Medicaid, you can have other insurance. So maybe someone is working and has a health coverage through a job. If they meet the income limits, they can also have Medicaid. What happens is the state will code it, and technically the private insurance must be billed first, and then Medicaid is the payer of last resort. It's known as TPL, or third-party liability. That's lingo in the state system. And so I think my takeaway around that is that if someone does lose that private health insurance, we want to be sure to report that to the state so that they can remove the TPL coding, and then Medicaid is the primary payer. The exception with the private insurance is someone cannot have ACA marketplace coverage, so Obamacare and getting the subsidies and all of that, and also receive Medicaid. That would be the exception. We're really talking about employer coverage and whether that's an adult or all kids. All right, so let me just check questions real quick to see if there were any questions about these programs, and it doesn't look like it. Hopefully everyone can see the chat. I'm having to go in when I go down to my toolbar and click on the More section to pull up the chat, so just FYI about that. All right, so let's move into these core eligibility rules. So the factors influencing Medicaid coverage. I want to review first the citizen and immigrant rules, really the immigration status rules that we talked about in March. And then what makes Medicaid so much fun is that they have thrown tax filing status into determining whose income, who's really a part of the household and whose income to count. So we'll kind of walk through all three of these things. Please know that folks who have been certified as certified application counselors or ACA navigators, they have received detailed training about all of this. And so while we used to be able to offer a lot of ACA training in person, much of it now is online, but we can always dig deeper, and I'm actually hoping this fall to do a webinar on ACA again, kind of revisiting that. So if you are not helping clients on a regular basis, some of this may be a little confusing, and that's okay. I would remind you that the computer system that the state of Illinois DHS uses to make these eligibility determinations, it's programmed to accurately count people in the household or not. So as long as we are accurately entering, you know, who's in the household, what their tax filing status is, what the relationship is to each other in the home, the state will count it or not count it according to the rules. Well, let's review real quick that term, right? Qualified alien or qualified non-citizen. Remember, to access Medicaid, regular Medicaid, I should say, SNAP, cash assistance, that immigrant must have a qualifying immigration status. For persons who come in through family sponsorship or employer sponsorship, they have to have their green card or lawful permanent residence for at least 5 years. So many people refer to that as the 5-year bar. But then remember, as we talked in March, for those of you who were there, that there are many immigrants who have a special immigration status or a humanitarian status. And so many of those might be refugees or asylees. We may see some other humanitarian statuses related to Cuban Haitian entrants or other conditional entrants. We'll talk again about abused non-citizens and their parents and children. There's a couple of different forms of immigration relief for that population, and then ultimately benefits access. I'm also giving you the link here for the complete listing of those exceptions or special Medicaid qualifiers. Excuse me. And they have it both for the medical programs. I think how they group it on the DHS policy site, it's actually medical and cash. And then SNAP is a little different with some of these special qualifiers, but the link is there for you. And I don't know if you've been to the IDHS website lately, but they have recently revamped it. I had a moment of panic. I couldn't find the policy manual at first, but it is there. It's just buried a little bit. So if you access the policy manual frequently and haven't been able to locate it, send me an email and I'm happy to kind of walk you through it. And then remember, there are always exceptions to these qualifying immigration status rules. One of the things that makes this work a little challenging is that there are always these exceptions. But again, it's okay if we don't always memorize or have all of this in the head, as long as we are entering the information on the application, submitting a complete application. The state system, IES, or Integrated Eligibility System, will account for all of that. So again, pregnant women, children in Illinois, no immigration status requirement. And then I'll talk a little later about the emergency Medicaid program for non-citizens. So we will get into that a little bit more and about what that means. And as we talked in March, but always bears review on, is the fact that so many of the families that we serve have mixed immigration statuses, right? You could see any combination. So in this case, we're going to revisit T'Challa and Nakia, who are both undocumented non-citizens. They're married and they have 2 U.S. citizen children, and they're having a hard time making ends meet. If they need assistance, let me see. Essentially, what the state will do is look at them as a household of 4 to make the eligibility determination for the 2 children who are eligible. And if there were other statuses, maybe Nakia had an LPR card for more than 5 years, you know, same thing. They would need everyone's income, but then they would award the benefit, so to speak, only to those people with an eligible status. It's worth explaining because I know that there's a lot of fear, and a lot of fear around putting information into a computer system. And what we can assure them is that right now, as the state is doing these eligibility determinations, the policy is very clear. You know, if Nakia and T'Challa are on there in terms of relationship and what their income is for the children's eligibility, they don't need to enter a social security number. In this case, they don't have one, and they shouldn't. If for some reason they're using someone else's social security number for work purposes, please, not that they'll disclose that, but that doesn't go on any application like this. If someone is not requesting Medicaid for themselves, they do not need to include a social security number. Some undocumented immigrants do file taxes with what's known as an ITIN number, or an individual taxpayer ID number. And that also, it looks like a social number, but that does not get entered either. So hopefully this is a bit of review for those of you who did attend in March. And we can, if there's questions, we can come back to that. So I am just checking. So I am going to check questions real quick. So we have a question: did I understand correctly that all children under 19 are eligible for Medicaid regardless of their citizenship status? And yes, that's correct, as long as the family meets the income guidelines. So if it's an undocumented child, but they're over 318% of FPL, they would not be able to get Medicaid. And that's a Medicaid thing. If they're undocumented, they are not eligible for cash assistance. They're not eligible for SNAP. And then the second question is, if both parents don't have a current legal status, the family, meaning children, could still qualify for TANF. So if the children are citizens, or if the children have LPR past the 5 years, so they're a green card holder more than 5 years, yes, technically they qualify for TANF, and the benefit would be awarded for children. If the parents don't have a legal status, though, I would caution them. This has been true even before the revised rules to public charge went into play. But if TANF would be the family's sole means of income, and then later the parents have a pathway to a green card, USCIS could look at that children's use of benefits. It's really the only time, because it's cash assistance. And if it was the family's sole means of income, they may look at that in their public charge assessment. Again, this is complicated, and so we would encourage a family in this situation to reach out to immigration experts to really talk about the children's use of benefits and whether or not that would be a factor. And I can tell you that if a family is qualified for TANF based on their very extreme low income, even with the final rule, again, cash assistance has always been subject to public charge, but now with the final rule and the emphasis on this totality of circumstances, if you recall from March, we kind of talked about how now when people are applying for their green cards, it's not just use of benefits that the immigration officials are going to look at. It's also everything from age, education, income, household size, and very, very low income for TANF would be a negative factor on that totality of circumstances test. So caution, but technically, yes, as long as the children have an eligible status, the children would be eligible. Okay. So let's talk a little bit about income and those tax filing rules and have all sorts of fun with that, right? There we go. So those of you who've been helping with Medicaid and possibly ACA marketplace applications for a while, you've heard this term MAGI, modified adjusted gross income. And so we call it MAGI or MAGI budgeting rules. And it's for most of the Medicaid programs. The exceptions to that would be AABD and health benefits for workers with disabilities. And I think those are the major exceptions. So, but essentially what they do is they look at all income now. Historically, people were familiar with the fact that if someone was just receiving Social Security retirement, that's not necessarily taxable income, that people may or may not file taxes on that. But it does count for Medicaid. And so, you know, they looked at all of this. And just historically, if you're interested, the reason for these income counting rules really comes out of the Affordable Care Act or the ACA, because they did throw tax filing rules into it. And before that, you know, all 50 states may have had different ways of counting a household's income to make a Medicaid determination, and the IRS wasn't going to use 50 different income counting rules, and so they had to come up with a uniform way to determine what income counted for health coverage, whose income in the household, and so forth. And so that's kind of where we've been dealing with MAGI since 2014. So I kind of said this, but these are the Medicaid programs that use MAGI budgeting rules, which essentially means that it does consider a person's tax filing status. And I'm going to walk through that in detail for you. So it's all of our ACA, our adult programs, all kids, moms and babies. And then the non-MAGI programs I already mentioned, and this also you can think of also like the SNAP and cash assistance programs as well. And we'll talk more about Medicare Savings Program. We'll introduce it a little bit next week. It kind of goes along with Medicare. So I often say a good way to keep it straight, MAGI Medicaid programs use tax filing rules. And it's kind of a combination of tax filing rules in relationship to others in the home. Whereas these non-MAGI rules are much more about the relationship and who's living in the home. But, you know, nothing is easy when it comes to public benefits. So what income counts? This is just a nice little cheat sheet. Really just enter all income, and the state will either count it or not count it appropriately. So on the left, you see all the different kinds of earned and unearned income that does count. You will see that unemployment does count for a Medicaid determination. There have been some exceptions with, so bear with me, I'm going to jump topics, but it popped into my head, so let me say it. Many of you may have heard that when it comes to unemployment, there are some extra benefits going on right now due to COVID-19. One of those benefits for traditional unemployment or current unemployment recipients is that they're getting an extra $600 per week. That extra $600, there is an exception to that. It doesn't count for Medicaid, so just FYI. And there was a policy release about that. That ends, though, I believe that goes through most of July, and then that will end anyway. So the income that counts on the left, and then some things that are not counted in income. So if someone's receiving TANF benefits or SSI, which is different from Social Security disability insurance, but it is for people with disabilities. That's that supplemental security income. If someone's receiving food stamps, that does not count as income. If someone's receiving child support, it does not count as income from Medicaid. And I don't remember if I mentioned it in March, but just a heads up, child support, if you're receiving child support, it does count as income for SNAP. So if you're doing an application for someone and they're applying for both SNAP and Medicaid, you would report the child support. And then on the back end, the IES, the system would count it for Medicaid, would apply it for that determination, but would not count it for SNAP. And so sometimes these are things we make sure get budgeted correctly in a client's benefits case. And then there's some deductions, and you see a couple crossed off, and that was due to the tax bill that was passed, I guess it was 2 or 3 Decembers ago. I'm losing track of time. The Republican tax bill that was passed a couple years ago that made a lot of changes to deductions overall. That did change this and have a slight impact as well. So again, not up to us to necessarily remember all of this, but we would enter it into the computer system and then the state would make that determination. So I started doing benefits work back right at the time the ACA was rolling out. You know, before that, most of my work had been in public health and doing both HIV prevention and HIV case management. And it was before ACA, so we had maybe a handful of clients who had received a disability determination and therefore were able to access Medicaid. So I personally wasn't that familiar with the old household rules for Medicaid. But for those of you who had been doing that for many years, it was a big change. And even for me, being brand new to this whole health coverage application and eligibility, the eligibility rules, I still had my aha moment. It took me a couple times. I think I had to sit through the ACA training at least twice. And if any of you were there were these exercises about determining the household groups. And we're going to do a couple of examples here in a moment. And I finally got it probably after the second time going through the exercises where, oh, I get it now. There might be 5 people on the application, but when it comes to Medicaid, depending on their relationship to other people in the home, as well as their tax filing status, you might have 5 different Medicaid decisions. So that's what I'm going to try to do, is walk through that for you right now. But again, just remember that as long as we are entering that into the ABE application, it will determine it. It's not up to us to make these decisions. It's up to us to enter it accurately into the application. So yeah, so eligibility is basically individually determined based on all of those things. And let me just double check, because I see that a question did pop up. So before I start diving into this, because those of you who've been around know that it can be a little complicated, right? Oh, so the question was, can I explain again the child support? So bear with me, let me just address that. So child support, if someone is receiving child support and it's unearned income for their household, that counts as a Medicaid. It does not count. I said that wrong. So you're receiving child support, it does not count for Medicaid. If you are applying for SNAP, the child support receipt does count for SNAP. So again, it's not up to us to decide whether or not we're going to list child support, because some of us who've been around a long time know, oh yeah, child support doesn't count for Medicaid, so we don't need to list it on ABE. Well, we kind of do, especially if down the road the person might need SNAP as well. And chances are, if it's an adult and they're eligible for Medicaid, they're likely eligible for SNAP. Okay. Thanks. Sorry, if I had a moderator, we would be able to answer those questions in real time in the chat. All right. here comes the fun. So Medicaid and tax rules. When you think about someone who is applying for Medicaid, that applicant is gonna fall in one of three categories, right? And I really appreciate our partners at the Center for Budget Policy and Priorities, or if you've ever attended some of their ACA health coverage webinars, Health Reform Beyond the Basics. They're awesome. There's some really strong experts there. So this slide is from them, and essentially the applicant is either going to be a tax filer, so they're the ones who's filing taxes. They're not claimed as a tax dependent, because remember, someone could be a tax dependent and also filing a tax return. But we're really, in number one here, we're really thinking about those persons who are tax filers and they are claiming others. They're not being claimed by someone else. The applicant could also be considered a tax dependent. And so the reason these categories are important is because that tax filing status is going to determine how many people are in their household, essentially who else is on the tax return. Now with tax dependents, there are three exceptions, and I'm going to talk about that next. And then we're going to go through some examples to just see how that works in real life. And then you may also have people who either they don't know if they're a tax filer or a tax dependent. That can happen, especially if you're working maybe with a pregnant teen, or maybe someone who just doesn't know how they're going to file next year yet. Or they are a non-filer in general, and they're also not claimed as a tax dependent, because basically if you don't have any income to report, you may not file. So we'll talk about that. And I already mentioned how eligibility for Medicaid is an individual determination. And so you'll see this is just a different way of saying what was on the previous slide. In this box, you're going to see I've listed on the slide a little bit this EDGE term, eligibility determination group. This is the state's language for household. So when someone is applying for state benefits, each individual on that application has an EDGE size, or an eligibility determination group. And again, it's based on all of these things, relationship and tax rules for Medicaid. So this chart, let's go column by column to kind of explain what it's really saying. And you'll find this also in the DHS policy, a different version, but very similar, in the state's DHS policy on MAGI budgeting. But these are the household rules now for Medicaid. So if it's category 1, that applicant is a tax filer who is not claimed by anyone else as a tax dependent, their household size, or their EDGE size, will consist of themselves, anyone else they might jointly file with, and all of their dependents. Now you'll see down at the bottom of that column, if you look all the way down, for married couples, it's clarifying a few things around that. And sometimes married couples do file separately in terms of tax returns. When that happens, if they are living together, they still go in the household. So you might run into situations where you have a married couple, but they're filing separately and they're not living together, then they're not part of the household. But if they're a married couple who files jointly, and maybe they don't live together, but they're filing jointly, then that person counts. So as you can see, all sorts of exceptions, right? And sometimes I even have a hard time. I have to sometimes sit with this and think through when I get a complicated case question, and I have to think through, okay, wait, where is this person falling in terms of this grid? So I've said it before, and you know I repeat things for reinforcement. Again, as long as we are entering tax filing status in relationship to others living in the home, the state's computer system will accurately account for that. The reason I like to get into this level of detail with you is so that you can say, hey, wait a minute, when something might not sound right, or when someone's case gets a little messed up and maybe we realize the state didn't apply something correctly. So tax filer, pretty straightforward, and hopefully married couples, pretty straightforward. Tax dependent. We'll get to the exceptions in a moment, but if someone's a tax dependent, essentially their household consists of the person who's claiming them and any other tax dependent in that tax filer's household or edge. So very similar to column 1. But there are 3 important exceptions to where then that tax dependency rule kind of goes out the window, and instead we're going to look at relationship rules similar to column 3. The tax dependent exceptions are when the tax dependent is being claimed by someone who is not their parent. So maybe I am claiming my elderly mother as a tax dependent, or maybe I am claiming my niece. She's not my daughter, but I'm claiming my niece. In those cases, if those people, if my elderly mother or if my niece needed Medicaid, their eligibility group would be dependent on what column 3 says, and more so relationship rather than that tax status. The other 2 exceptions are children who are under 19 who are living with both of their parents, but their parents are not filing jointly. I kind of refer to this as a child in common rule, and we'll walk through an example so that this makes a little more sense. But it also could be unmarried parents who aren't expected to file a joint return, or a married couple who is filing separately. The key here is that the child is living with both parents. And then the 3rd exception is where the child under 19 is claimed as a tax dependent, but by a parent who does not live in the home, so a non-custodial parent. So when you think about maybe families who have separated or there's a divorce, sometimes what happens is that the parents switch off years in which they claim the child or not, and sometimes it's just that they're claimed as a tax dependent by someone else, and that kind of gets a little outside of my scope of knowledge of how those agreements are set up. But the takeaway is, again, if they're claimed by that parent who is not living in the home, then the state's going to shift that child into the relationship rules in column 3. And so let's talk about column 3. Essentially, I keep saying relationship rules because essentially what they're looking at for adults is it's that individual plus their spouse or children under 19 who live in the home together. So there's some relationship there. And then if it's the children, again, children under 19, then the household is any other siblings under 19 and their parents, if their parents are also living with the child. So let's say I take in my niece and nephew, both, right, for whatever reason. And they're living in my home and I'm claiming them as a tax dependent now, and they both need Medicaid. The state will look at that and see, well, I'm not their parent. They'll ask me they'll ask on the application about where the parent is. But when they look at my niece and nephew, if they're each other's only siblings and there's no other parents in the home, they're going to look at that family as a household of 2. Because they're just looking at the children and the other siblings under 19. If the sibling is over 19, then that doesn't count. So I know how confusing this is. Even just talking it out right now to the screen, it sounds confusing to me. So let's walk through a couple of examples. And some of you may have picked up on my theme. I can't remember if I used the same characters last time, but in this case, we have Thor and his spouse, Jane. We can be hopeful, right? Anyway, Thor and his spouse, Jane, providing ongoing support to his father, Odin. And Odin has recently lost his job. Odin's here in Illinois. He comes to you. He needs help. You learn that Thor and Jane do claim Odin as a tax dependent as they file their joint tax return. And if Odin needs health coverage, what is it? So let's take a quick poll. So if you think about this example, Thor and Jane claiming Thor's father Odin as a tax dependent, what is Odin's eligibility determination group size? All right, I'm going to close the poll in about 5, 4, 3, 2, 1. So if we refer back, so the correct answer is 1. So I'm going to stop the results. So Odin is claimed as a tax dependent, and so we often see people think back to, it's the tax filing rules, right? That, oh, it's the tax filers and all their dependents, so household of 3. But remember, Odin falls into this exception as a tax dependent. He's being claimed by someone who is not his parent. He's being claimed by his adult child. So that's why Odin will fall into the relationship rules. In this example, Odin does not have a spouse or children under 18 living with him, so Odin would be an edge of 1 or a household size of 1, and they will only look at Odin's income. If you report on the ABE application that Thor and Jane are his tax filers, so to speak, again, the state should not count Thor and Jane's income for Odin's Medicaid eligibility. And they don't live with him, so there's not a concern there with SNAP or anything like that. Okay, let's do another one. We've got Darcy. Darcy, age 15, is pregnant and lives with her mom and 2 younger brothers. For some reason, the family does not have health coverage. We see what Darcy's mom's income is. And so let me launch another poll real quick. So when we think about this, again, Darcy, age 15, pregnant, lives with mom, 2 younger brothers. What is her edge size? And I'm going to close polling in 5, 4, 3, 2, 1. The correct answer is 5, though, and the reason why is, remember, that fetus or that unborn child does count for Medicaid. It wouldn't count as a household size for a SNAP, but it does count for Medicaid. So this family, we don't know why they don't have health coverage, but we definitely want to look into that. Maybe there is an immigration status concern, but now that Darcy is pregnant, she would be, she's already eligible. The children are eligible under all kids, but anyway, so that's that example. And then I don't have a poll for the next one, but I am going to ask you to think about it. So first, we've got just the setup. In this case, we've got Gamora, who is a green card holder. She's been here for 3 years with her permanent resident status, and she lives with her boyfriend, Peter, who's a U.S. citizen, and they both work and file their own tax returns. So as it is right now, Gamora and Peter would do their own applications for health coverage. And depending on their income, if they're not offered health insurance through their work, Gamora could access health insurance through the ACA marketplace. She's not eligible for Medicaid yet, right? She's only been here for 3 years as a green card holder. Peter's a citizen, so wherever his income falls, he can either get Medicaid or health insurance through the marketplace. They would each be considered a household or an edge size of 1, because right now they're single. Even though they live together, they're single, they're not married, they don't file taxes jointly. But what happens if their family expands, right? So let's say they get pregnant, they have a child, still not married, and they've made the decision as their household that Gamora is going to claim Junior as the tax dependent. And so how does this really work out? Well, if we remember, it's a combination of tax filing rules and relationship. And if they're all living together, it's going to look a little different. So I don't have a poll for this, but I'm going to let you sit with this just for maybe 30 seconds or so and think in your head about, okay, if it's Gamora's eligibility, what's her edge size? And let's remove the whole immigration status consideration for a moment, and let's just say she has since become a citizen. What would her edge size be? What would Peter's edge size be? And what would Junior's edge size be? And while you think about this, I will take the opportunity to answer a question that came in. So for SNAP, this is the question. So for SNAP, we do not count unborn child as a household member, but only for Medicaid. That's correct. On the ABE application, where it comes into play is it asks if anyone in the household is pregnant. So as you enter information about each person on the application, one of those questions is if anyone is pregnant. And if we mark yes to that, that's again how the state system will know to count the pregnancy for Medicaid, but they will not count it for a SNAP. And this is what the answers are. So for Gamora, if she needs health coverage, she's going to be looked at as an EDGE or a household size of 2. She's a tax filer. She claims 1 dependent. Putting the immigration status issue back into Gamora's case, you'll see that after she loses moms and babies coverage, we will need to refer her to the marketplace to re-engage with health insurance there. For Peter, for the dad, single individual, yes, he's living with partner and child, but because of his tax filing status and his eligibility, they would look at him as a single person, so just his income would count. And then Junior is a tax dependent. He lives with both parents who are not married and not expected to file a joint tax return. And because of that, Junior falls into an exception. So many people often think Junior's EDGE size is 2, just him and his mom. But actually, because he's living with both parents, Junior's EDGE size is 3. And so therefore, they will look at both parents' income to determine Junior's eligibility. For the most part, because all kids have such a higher income limit, it usually works out just fine. But I have played with the numbers and examples before, and then last year actually ended up with a real life example where this actually got a family into struggles with their health coverage because mom had Medicaid when she got pregnant and then had the baby, and that coverage lasts for the baby up to a year under moms and babies. But ideally what you want to do is you want to get that baby enrolled in all kids. It was this exact situation, and the way dad's income worked out, it actually was so high that the baby wasn't eligible for Medicaid. And unfortunately, they had waited too long and ended up where they missed open enrollment at the dad's job for health insurance for the baby. It was past ACA marketplace enrollment. They just assumed that the baby would continue on Medicaid. And it was really challenging because the baby had disabilities as well, and had high medical needs. So our ask was, because they had just missed missed the enrollment through the job, but because the Medicaid was ending, we encouraged them to try to go back to the job and see if they could get a special enrollment for the baby. And I never did hear what ended up happening. It's pretty rare that we see that, but just know that it is important. So when we think about the timing and relationship and all that, that's just another reason to kind of revisit this, because they just assumed, they weren't married, they assumed the baby would just stay on Medicaid because mom had Medicaid and mom was eligible. Okay. So that is a lot of information, I know. Let me pause here and just see if there are any questions about these core eligibility rules. And we're not going to go into great detail about application today, but we will revisit ABE and manage my case next week as well. All right, so ABE, right? The abe.illinois.gov, the online application system. This is where people can apply. If we are helping someone apply, for most of us, we are helping them create their own ABE account to submit an application online. There are some providers who are considered an official ABE partner. These are usually healthcare providers. These are usually all kids application agents or MPE providers. That's Medicaid presumptive eligibility for pregnant women. They would log in as themselves, their entity, their provider number. But for the vast majority of folks that we train, you are helping the client create their own account. And so there are some things to just think about in terms of making sure they know what their username and password is, and helping them remember their login information and so forth, their security questions, all of that good stuff. Now, people have the right to also apply either over the phone or by mailing, faxing a paper application, by going into the local office when the offices are open. But we have for a long time encouraged everyone to please submit their applications online. You will have a record then of their application. Too often we hear horror stories of things getting lost in the mail, or the fax machine is broken, or the fax machine ran out of paper, the faxes came in over the weekend, all the papers fell on the floor, and how did they put it all back together again? So there's just been too many challenges with that. Sometimes when the office was open and people would go in and say they want to apply, each office handles it a little differently. Some people or some offices will hand the client a paper application, they fill it out, drop it in that box there. Others were trying to do kind of real time, and so maybe they would have the client wait and then pull them back and they'd kind of do the application in real time. I would say that was probably rarer, but I know that some offices were trying to get to that point. So I can't stress it enough to apply online. A little later, I'm going to talk about some of the workarounds that have had to come about with Medicaid applications in particular, because we are all working remotely, and how can we assist someone online? Because even when we are sitting with someone side by side at the computer and we've helped them create their ABE account and we're helping them fill it out, technically at the end you're supposed to have that client type in the electronic signature. It's technically their signature. But HFS did release a workaround for Medicaid applications about how we can submit online by documenting the client's verbal consent. So I'll show that to you a little later on a slide. Once they submit an application, they'll get a tracking number, and so that's pretty key to follow up if there's a problem later. And at application, it's really best, you don't have to, but if you have their proofs, especially proofs of income or Illinois residency or other things, it's really helpful to attach those to the application at the time of application, because that way the state has everything and can make that determination. If they can't verify any of this electronically with their database matches, then they're going to have to send a letter to the client, ask the client to submit whatever proof it is. We need your pay stubs for the last 30 days, or we were unable to verify your immigration status, please submit a copy of your document, whatever it might be. So it's really best to submit this at time of application, and especially now, even with some things with COVID-19, HFS has been doing some flexibilities, and DHS has also done some with the SNAP side of the world too. So it really is best to try to submit all of that if you can at the time of application or shortly after. What happens after an ABE application is submitted is that the local office it was sent to receives an email alert, and they have to go in and then take that application and register it in their system. And my understanding is that even after registering the system, that people can still submit proofs through their ABE account. And it's supposed to create a task to the office, but sometimes that just doesn't seem to be looked at if the proofs are submitted maybe a week after application. So in the best circumstances, that's what we would do, but obviously right now it's a little challenging. I've heard of some interesting workarounds even with signatures and stuff, where like one agency in our region was doing a drive-through to get signatures or to get proofs, like where people would drop off things and it would avoid going into the office. But obviously that depends on a client having access to transportation or being able to prove it or bring proofs. One other word about proofs, you heard me say if the state was unable to do the matching in their databases. So the state in many cases can verify Illinois residency if someone has a state ID or a driver's license, right? They can check citizenship or immigration status. They do a data match in the SAVE system, which is systematic alien verification eligibility, something they do a data ping, just a ping with the federal database on that to verify. They can do a data match with Social Security, IRS, in many cases can verify things. Income, though, is dependent on whether or not the person's working in a job that reports either to the Illinois Department of Labor database or even is filing taxes and has an IRS return. And so that's why I encourage at a minimum include proof of income, especially recent income, or if there's been a change. I once helped a woman who whose employer was reporting on a quarterly basis to the Department of Labor database, and by the I think they had last reported in June. I met with her in late August. In July, end of June, July, she had become very ill, and her wages dropped significantly because she was just unable to work full time like she was. But she never submitted her recent pay stubs when she applied. And of course they denied her because they only saw the Department of Labor database. So once we were able to submit the proofs, they were able to get her Medicaid. After submitting application, and again, we'll talk a little bit more about application next week, but after submitting an application, if you have someone with an urgent medical need, there's a couple of different options. And so keep in mind kind of what I'm talking about now is pre-COVID, or if we ever return to some sort of normalcy, which I know it'll be a new normal, but that's another story. But if you have someone with an urgent medical need, chronic illness, even severe mental illness, medication needed, third trimester of pregnancy, any of these things, we do have a mechanism to get applications expedited, and that is by emailing hfs.aca@illinois.gov. You would just type up a very brief summary of what the health needs are, what the application tracking number is, and so forth. Do not send any Social Security numbers, and depending, you may need to have a release of information or be designated as the client's approved representative for HFS to respond to you with a decision. They've really tightened up some of their data security rules. So it used to be you could email things and they'd let you know what the outcome was, but more often than not, if I email someone's information on behalf of an agency, they'll just say, thanks, we'll look into it. And I never hear the outcome because I'm not involved directly with the case. So just a heads up that if you are expecting some sort of acknowledgement, that you'll have to either have a release of information to communicate on their behalf or be the client's approved rep. But they have been very responsive, especially during this remote work time. And I just have an example here with someone with significant medical needs, and we don't want her to have to wait, 90 days or more for application to be processed. Many of you may be aware that the state had a significant backlog when it came to Medicaid applications. They have been catching up pretty good during this time, is my understanding. And as you'll hear in a moment, there's also another mechanism for them to help get people care during this time, and I will get there in a little bit. So again, we'll revisit a little bit about application and also redetermination next week. But let's fast forward to persons are approved for Medicaid. What happens next? Well, in most parts of Illinois at this point, it's statewide, they will likely have to pick a managed care plan. So they'll be approved, they'll receive notice that they were approved for Medicaid, they'll get that paper HFS medical card, and for the immediate need, they'll be able to go to any doctor that takes fee-for-service Medicaid using that HFS medical card and their RIN number, their recipient ID number. But then shortly after that, they're going to get a welcome packet as well saying you need to pick a plan, a Health Choice Illinois plan, and they'll need to enroll in a plan that will then kind of coordinate their health care. I describe it as HMO Medicaid. It's a health plan. It's a private insurance company administering their Medicaid. And once they enroll in a plan, they have a provider network. They can't go to just any doctor that accepts Medicaid. They have to go to a doctor that accepts that Medicaid health plan or that managed care organization, also known as MCO. So you'll hear that term thrown around a lot too, MCOs. This is the client enrollment website, so you can learn more about what plans are available in your region by going to this website. And let me talk a little bit more about it. So I've kind of already talked about what it takes. You know, they'll get the notice now, and they have an initial enrollment period of 30 days. So once they kind of get that packet, they have 30 days to pick a plan. If they don't actively pick a plan, they will be auto-assigned to a plan. And we want to avoid that. We want people who are new to Medicaid to pick the plan that meets their needs. Now we keep getting smaller and smaller in terms of the number of plans available in Illinois. We now have only 4 plans statewide and 1 extra plan in Cook County. So Cook County has 5 plans, and I'll show those to you in a moment. Once they are either enroll or they are auto-assigned, they will have an enrollment effective date. Essentially, if they pick a plan by the 15th of a month, their plan should be active the very next month. So if I pick a plan by July 15th, it should be effective and first date of coverage August 1st. If I don't pick my plan until July 23rd, then my plan will not be effective until September 1. But all of this will be told to them when they enroll with client enrollment, and they'll also receive they should receive confirmation of that. Once someone's in a plan, they're also able to look it up in Manage My Case if they're able to use that customer portal. And again, we'll talk about that next week. And then once a year, 60 days prior to their anniversary date with the plan, they'll be notified that this is their selection period where they can change plans or not. They can stay in it, and then sometimes other things happen, like plans closing throughout the year, and they get a new enrollment period to select a different one. I'll come back to that. But think of it kind of like health insurance. I think it's important to just, I've mentioned a little bit about effective date, you know, what that effective date is. That is important for clients to know, because once that plan is selected or they get assigned to a particular plan, that effective date, let's say it's August 1, is important to know, because they have an initial period of time, an initial 90-day switch period, where if they realize, oh wait, they assigned me to plan A, but my doctor doesn't take plan A, I really need to be in plan B, they only have 90 days from that effective date of the plan to switch. They can switch plans once after they've kind of been put into one or selected one. And so whenever possible, you know, educating consumers about, hey, these are the plans in your area, you know, who do you see now, what hospitals take these plans, and help them make the decision that best meets their needs. Once that 90-day switch period passes, they are locked in for that 12 months until their next anniversary date. Now they're allowed to change doctors. That's what PCP refers to. They're allowed to change doctors, but they are really, they'll be locked into the plan after that 90-day switch period. Okay. And Medalia, I'll come back to your question. I'm gonna keep going for a few moments. Already mentioned, you know, it's that 60 days before their anniversary period with the plan effective date that's their open enrollment. And if they do nothing, it should stay the change. Part of the challenge has been that many of you know, for Medicaid, there's also an annual redetermination or just a renewal of eligibility for Medicaid in the first place. And so that's what this note is. And so someone may have gone through the redetermination for their Medicaid eligibility, and then it might be, depending when their effective date of their plan was, it might be a couple months later that, oh, now it's time for your open enrollment for Health Choice Illinois. And I know some people confuse the two, and it's like, well, I already did that, I don't need to do it again. But you know, this is something to just pay attention to. If they really aren't happy with their plan, they want to pay attention to when that open enrollment is. And then again, Manage My Case will list when their plan anniversary date is. So for customers who can use Manage My Case, we can help them keep an eye on that. And this is just an example. Let's say someone applied and requested backdating, and so backdating of Medicaid until April 1. I kind of didn't mention that at the beginning, but with most Medicaid programs, you can request up to 3 months of backdating. So if I apply today, but I had medical expenses the last 3 months, I could request that the state backdate Medicaid. So in this example, we have Peggy. Her Medicaid was approved in July, backdated to April 1. So that's her Medicaid eligibility date now, is April 1. She doesn't select a plan though until September 3rd. And so then her MCO, her health plan, her Health Choice Illinois plan, starts October 1. She'll complete her RED for Medicaid in March, in advance of that April 1 day. But then come August, she's going to get notice that it's time for her MCO open enrollment if she wants to switch. So that's kind of an example of the timeline with all those different effective dates. And in my example, Peggy's current doctor only accepts fee-for-service, has not enrolled with any of the health plans. And that's another issue we could talk about. So therefore, if she's gonna, if let's say her doctor doesn't take any of the Medicaid health plans, she's gonna have to switch doctors and choose a new primary care doctor within her MCO network. So I'm gonna pause here for a moment because I think that's what Migdalia's question was about. So let me open that up. So it says, oh, and it was a private question. So maybe I should respond to that privately. No. And in fact, let me just read it quick and everyone just bear with me. Okay, so it's kind of talking about, so Medallia works for Community Health Partnership of Illinois. They're a community health center. And so just kind of talking about if they're able to accept something or not. So since that was sent to me privately, I will go ahead and respond to that privately, probably after the session or at the end of the session, if that's okay. Because then we can get into more detail. Sorry about that. All right, more information than you probably want to know is available on the HFS's care coordination page. So I've given you the link here. I would just point out a few things. You can find some really helpful contact information. If you look down on the right column, you can actually see the contract that these MCOs are supposed to abide by. They have since updated their map. This is an old screenshot, but it looks very similar. I would also point out the sample transition and expansion letters. This can be really helpful information. You can get a copy of the client notices that are sent, especially as these health plans change. And there have been some recent changes. So it's something you might want to check out if you start getting some questions. Also some contact information for the plans themselves. Another good resource is the Illinois Association of Medicaid Health Plans, and I think I included that at the end as a resource, and if not, I'll be sure to send that out at least with the next one. These are currently the plans that are available in Illinois. So 4 statewide: Blue Cross, Illini Care, Molina, Meridian, and these are also available in Cook County as well as County Care. Couple of notes, recently, actually last year, Harmony merged into Meridian, so some people may have heard of Harmony. I can probably take that off. And this then hot off the presses, effective yesterday, Next Level, which was only available in Cook County. And I know we have some Cook County providers here today, so heads up. Next Level has closed. They had a failed buyout or merger. There's been all sorts of mergers and things happening. And so they are technically closing. Now, as of 2 days ago, there was no information on the HFS website about that. Very frustrating. For those of you on Help Hub, there is some information. There was a question asked and some information, and we just got a hold of some of the transition letters. If you need that, please message me after the session and I can forward you that, but hopefully HFS will get that up on their website soon. Long story short, folks who were in Next Level now, they'll probably automatically be shifted to another plan. And if they don't want to be in that plan, they do have a switch period. So they'll just need to call client enrollment services. So I'm just not sure how clear the communication has been to customers up to this point. And these managed care organizations must cover everything that Medicaid does. And then what they do, how they attract new customers, is really by offering above and beyond. And before I go further, thank you, Anne. You reminded me, let me go back. The DCFS population is only youth up to 18, correct? Do 19-year-olds apply, need to get released? And so let's talk about that. So Illini Care, and this actually is changed, it has changed a little bit. So let me do my best to remember, and apologies for not refreshing my memory before, but I can always follow up with this before next week. So originally, the DCFS youth, both the current youth in care, meaning people who are wards of the state whose medical care is being managed by the state, by DCFS, whether they're in a foster home or a group home or whatever the setting is. Originally, we're going to have to go into managed care, and we're only going to have the choice of Illini Care. They haven't been talking about this much, but that has changed due to a lot of pressure. In addition, my understanding is this rollout into managed care, I thought, got delayed because of COVID. So I need to go back and double check that. So I will make a note to do so. Apologies, it's just one of those things that slipped away before today's session. The other population is the former youth in care, and same thing, they were going to be put into managed care too, but would have the option of choosing whoever, whatever plan they wanted. But I will get some better information about this because it's been confusing and concerning. The same thing with some of the children who were on, I can see the initials in my head, sorry, the medically fragile technology dependent children. There were also some changes around that. So I can revisit that next week. Apologies for forgetting to get you the most up-to-date information. Okay, so thanks for asking that question. So I was saying they must cover everything that Medicaid covers, right? And then also the way they attract new customers is really by going above and beyond that. But it is important, you know, it's choosing health insurance. So we want people to basically think about not only the providers in these plans networks, the hospitals, the specialists, but also, you know, what the other things are that are available. Some of them offer some really neat things, some wellness incentives, you know, gift cards for getting immunizations on time or getting flu shots, gym memberships, Weight Watchers memberships. For eligible new moms, possibly car seats or a play yard or things like that. And the idea is that they're trying to keep their patient population healthy so that they don't use the healthcare system as much. If you can keep people healthy, right, you don't go to the doctor as much, and therefore you can save money. You're not paying out for a lot of visits. So that's kind of the theory behind managed care in general, whether it's Medicaid or private. So I kind of listed those plans. I just want to emphasize those are the Health Choice Illinois plans. Those are for all kids and your adult plans. For your seniors, for your AABD program recipients, they may be offered the MMAI program, which MMAI stands for Medicaid Medicare Alignment Initiative. So your dual eligible population. We will talk more about this next week, but there are different plans than what was listed, and it's technically voluntary. This is the only population that can opt out of the health coverage part of it, out of Medicaid managed care, because it's kind of, again, a demonstration project, if you will, with the feds. So stay tuned. I think my takeaway for today's point is that they have different plan options and there's just different rules for that population. But I figured we would talk about dual eligibles next week. these MCOs, these Health Choice Illinois plans, are getting paid by the state to offer care coordination, which is interesting because some of you do care coordination. But they do have care coordinators who are supposed to help those clients really get the services they need. And if there's prior authorizations needed for a service or something else, you know, transportation, whatever it is, they're supposed to be the ones helping with that, getting referrals to a specialist that's in network. And if they don't have any specialists, making sure they get that client connected to a specialist, even if it's out of network. So we need to make sure that our members or our clients are contacting the plan and asking for a care coordinator. And if they don't have one assigned to them, they can request one. Care coordinators are usually assigned based on the level of health need. And so when someone's new to a plan, they get screened based on either past usage of the healthcare system, or they'll get a telephone screening or a survey in the mail to fill out. But they can request a care coordinator as well if they need assistance. And there are a lot of standards that the MCOs are supposed to abide by, things like an adequate provider network and so forth. And so sometimes plans are sanctioned when they're not meeting their contract requirements. The state's really in the state's interest to make sure that the system is effective. And so if there are issues or concerns, you always start with the MCO, but then there are avenues to pursue with HFS as well. And if you're interested in more information, let me know and we can talk about that. And then this kind of repeats the same thing, but basically we always have to start with the MCO. If a service is denied, we can't go right to HFS. We have to start with the plan, figure out why that was, and then if we think it's appropriate, you know, certainly help a client file a complaint, an appeal, whatever the situation may be. But yeah, they have even standards, you know, in terms of geography, like how far before someone should have to travel to get care. Transportation is handled a little differently by each MCO. Some contract with First Transit, some do their own. So yeah, if you run into any issues, always have the client start with their plan. Now, I know many of you run into this, and this is probably the biggest challenge with Medicaid managed care, is really provider networks, either the provider, whatever level it might be, doctor, nurse practitioner, physical therapist, hospital, whatever. Maybe they were in the plan network, but then for business reasons drop out. It's an incredible challenge, and we were really concerned about that, especially as the state was pushing for the DCFS population to get enrolled into managed care. We're like, wait a minute, these young people have such needs in terms of healthcare, mental health, etc. You know, by putting them all into one plan, what are you doing? There, you know, in our area, there aren't, you know, not all the hospitals take Illini care, or there were just barriers to accessing care that advocates were concerned about. But that goes with whatever population or service. And I will say that the plans have been working hard. And I know that Illini Care, I attended one of their provider town halls, really working hard to make it as easy as possible for providers to engage in their plan. And I can't speak to the others, and I'm not paid by any of these managed care plans. I'm just basing this on what I viewed in their town hall. But just as an example, what they were offering is like, yes, provider, you can enroll and take, you know, 50 of our patients, that'd be great. Or if you want to limit it to just a few patients, or if you want to enter into single case agreements for just this one patient you've been treating, we'll do that for you. And so the plans were really trying to be accommodating. And so ultimately it sometimes comes down to a provider business decision as to whether or not they're willing to engage in that. And so you know, in terms of advocacy, sometimes it's on the plan side, sometimes it's on the provider side, and sometimes the provider wants to, but they're part of a larger health system, and it's someone else in another part of that system that's making the managed care decisions. So I share all that context because that's what your patients are navigating through. And ultimately, with this example, you know, what do we need to know to help Steve? Because ultimately it falls on the patient to try to navigate this. Oh, I'm not in that plan anymore. You know, good luck. We can't see you. I don't accept that plan. Or you can pay out of pocket, which that's not possible for Medicaid folks, right? So what we can do is help Steve navigate that. And one thing to do is get back to a care coordinator or just even with the plan and ask for a referral to a new physician. You know, help him change MCOs if the provider takes a different plan, but knowing that they can only do that at certain times of year. Now, the one exception with this example is that if Steve is in the middle of treatment, every plan has what's known as a transition of care or continuity of care program. And so most coverage will last an additional 90 days where Steve could keep seeing his current doctor for 90 days while he switches so that his care is not interrupted. Think of someone maybe who's going through chemo treatment or whatever it might be. Maybe they have severe mental illness and need to have those regular therapy appointments and medication and so forth. The kicker is though that current doctor has to agree to continue to accept the reimbursement from the plan for these 90 days. The last bullet point just refers to home and community-based services waiver, or folks who are getting long-term services and support. So either services in their home or they're in a long-term care facility, they have a longer transition period. Here are those managed care resources. So I did indeed include the Illinois Association of Medicaid Health Plans. You as providers may find some interesting information. Just know they really are serving the health plans and really trying to be a liaison between health plans and providers. And I gave you already the link for the transition letters. Just a few notes, and I'll let you read most of this on your own. We'll talk a little bit more about appeals. I can't remember if that's today or next week, sorry. But anyway, this is regarding health plan appeals. So I already mentioned it earlier, but just reminding you that to start with the health plan, if they think something should have been covered, and we now can confirm whether or not that was covered, should be covered by going to the HFS website. But there is a 60-day time frame to appeal. So if a service was denied and it should have been, we only have 60 days to appeal. The good news is with managed care clients, they actually have an extra layer of appeal because they can also go to the state. So if it doesn't go through with the health plan, they can appeal to the HFS. All right, so in our last 20 minutes or so, well, I guess it is going to go 2 hours. Let's move through the special Medicaid programs and then some of the COVID-19 related flexibilities. So we'll talk about spend down next week, but that is a topic, a special program within Medicaid that I already highlighted. And then I want to talk a little bit about health benefits for workers with disabilities, emergency Medicaid, and VTTC. I'm not going to talk much about former Illinois foster children. The real note there is that they are able to continue on Medicaid regardless of income up to age 26 if they aged out of the DCFS system at age 18. And so that's why that's asked on the AID application. Health benefits for workers with disabilities. Remember we talked about AABD at the beginning and how that income limit is at 100% of the federal poverty level, pretty low income and pretty low asset limits. Well, if it is someone who is disabled who is working, this is like a Medicaid buy-in program. And the benefit here is that it allows a little higher income limit, right? Going from 100 to 350% FPL. It's also a higher asset limit up to $25,000. So I've given you the link here to the HBWD program. Again, it is like a Medicaid buy-in program, so the person will have to pay a monthly premium. But that premium is determined based on what their income is. So let's look at an example quick. So in this example, we have Bruce. He works at his local grocery store. We see what his current income is from the grocery store, right? So $250 a week, if I do the math real quick, I'm going to multiply that by 52 and then divide by 12 to get the average monthly, and that's about $1,083 a month that he's earning from the grocery store. But he's also receiving survivor's benefits. And if you're attending the Social Security training later this month, we'll talk a little bit more about what this is. But essentially, one of Bruce's parents passed away, and so he's getting a benefit based off his parents' work history of unearned income of $1,000 a month. And then he's also got savings. So if we did the math for Bruce, which we will revisit Bruce next week in the spend down section, just know that he is over the AABD income by a lot, right? It ends up being about that Bruce would have to show medical expenses of $995 a month, plus once a year meet an asset spend down of $3,000. So for Bruce, it might not be feasible to enroll in AABD because the spend down is so high. But with health benefits for workers with disabilities, he can buy into that program, and based on all his income, he would end up being able to keep all those assets. He would have to pay $81 a month for his Medicaid, but that's probably more manageable than that spend down would be. So that's kind of the benefit of the health benefits for workers with disabilities. Especially for folks with developmental disabilities. I don't know if any of you work with that population, but they may have access to other health coverage. He may be on Medicare due to his parents' history, or, you know, depending how old Bruce is and how long he's been working, he might be able to qualify, especially now that he's receiving survivor's benefits. He may be offered health insurance through his job as well, but many of them require the Medicaid, especially if they're going to need residential services. So it's really a specialty area with regards to Medicaid, but a huge benefit for that population. Emergency medical for non-citizens. This is for someone who doesn't have a qualifying immigration status, and they would have met all of the Medicaid income limits, residency, etc. And the only issue is they don't have a qualifying immigration status for Medicaid, and they end up in the emergency room in need of care. And so they have to meet those other eligibility factors as well. But essentially, this is the definition. And so it has to be like life-threatening, acute, sudden onset. It can't be that they go in for just something minor because they have no other source of health coverage. It has to be an emergent health condition. They have up to 3 months after the emergency event to apply, and basically this is a way to get the hospitals paid and reimbursed for health care. So let's look at an example. We've got Tony. He's undocumented, has no health coverage, severely cuts his arm. He gets to the ER. They determine immediately it's so desperate that he needs immediate surgery. He's going to be hospitalized. He's going to need physical therapy after all this stuff. They can apply for emergency Medicaid for Tony. Often it is the hospital who is submitting these applications, because in addition to just submitting an application, they need to submit medical records, they need to submit a medical treatment form, and then this is sent to DHS, and they have nurse examiners who are going to review the records and make sure that, yes, indeed, it meets their definition of emergency Medicaid. So just know that usually the hospitals are taking care of this, but we think it's important to make sure everyone knows that this is available. And the other thing, so let's say depending on Tony's needs, you know, if he's hospitalized after the surgery, there's a good chance that the emergency Medicaid will cover the emergency visit and the hospitalization if it's due to the emergency visit. But if he's discharged and then told you're going to need physical therapy to regain full mobility of your arm, that PT is not going to be covered because it's not at the time of emergency. If he's there and they also diagnose a heart condition, completely unrelated perhaps to this emergent event, or they diagnose cancer at the same time, that will not be covered by this. So just know it's really for that emergent event. I do want to mention, though, that HFS is treating right now COVID-19 as an emergent condition. And so for the most part now, when someone's going into the hospital because of COVID-19, they are looking at that, and they don't have documented status. You know, as long as they meet the income requirements, they are looking at COVID-19 as one of those emergent conditions. So the symptoms may not completely fit the definition of emergency Medicaid, but they are treating it as an emergent condition so that the hospitals can be paid. I'm also pointing you to a really helpful fact sheet about emergency Medicaid, including a little bit about COVID-19 that we put together at Protecting Immigrant Families Illinois. So it is available on this page. If you click on this link or you go to that link, there's a huge list of resources under resources and training. So you're going to have to scroll down to find that fact sheet in particular. I will just mention, I'll come back to COVID-19 in a moment. So applying for emergency Medicaid, we do so through ABE, or the hospital can do so. You can see as soon as you mark that the person's a non-citizen, it asks if this is a request for emergency medical. So that's nice to have that there. And then I already mentioned that medical documentation is needed. Also, end-stage renal disease. This is considered under the emergency medical for non-citizens policy. This is for people who are experiencing kidney failure. That's what end-stage renal disease is, and they're in need of dialysis. And this is limited coverage, again, for non-citizens who meet the income limits in Illinois residency. They don't have the lawful immigration or the qualifying immigration status, that we reviewed at the beginning. This coverage will only cover dialysis. It will not cover primary care. It's just to get them their dialysis. And often what you'll see is folks who have end-stage renal disease coverage, they might end up in the ER because of their condition for another reason. And even though they have this, this coverage, if they end up in the ER for something else, they are going to have to submit another emergency Medicaid application for that visit. So it's you know, little extra layers there, I guess is a good way to say it. Victims of trafficking, torture, other serious crimes. I think we talked about that in March for those of you who were there, but essentially for non-citizens who are either they're survivors of whatever the case may be. Maybe they were trafficked for domestic servitude or the sex trade. Maybe they were victims of other serious crimes or something, and they are in the process of applying for the immigration relief that's available to this population. So they're either working with a legal services provider to submit a U visa application or a T visa, or they're seeking asylum from the US government. While they're in that application preparation and pending application phase, the state of Illinois allows them to now apply for public benefits. It's state-funded benefits only. They still have to meet all those other eligibility rules, but it will provide access to cash, food, and medical while they're waiting for their decision from immigration. And I'm not going to spend much time on that. Now, what happens if you end up helping someone apply for this benefit under this rule? The special units up on Hiawatha in Chicago is the office handling these applications for the state. So you can email this email address, let them know that you submitted a VTTC application, and they should pull it from the local office to process. If you have questions about that, let me know. Usually, like I said, these are folks who are engaged with an immigration services provider, a legal services provider already to do the immigration paperwork, and this is the benefits side of it. And then if they're approved for a U visa or a T visa, then they gain federal eligibility for benefits. Okay. I'm going to be right on time. So some of the COVID-19 related changes, I will be curious if you're hearing or seeing things or if there's confusion. So definitely let me know. And before I get into COVID, we had a quick question about asylum. So to be clear, if I speak to someone who says they intend to apply for asylum and they meet all the other requirements, they can apply for benefits. And yes, there is documentation that is needed. So thank you for asking that question, Pat. Some of the examples might be a statement from their immigration legal services provider that they are working on that. If they've already submitted an application to USCIS, they can submit the receipt of that application, and there's some other examples of proofs as well. It's not just that they're like, yes, I am seeking asylum and I'm thinking about doing it. It's know that they're actively working towards it. And there's a really helpful fact sheet from Heartland Alliance as well that I can send out. So, all right. So COVID-19, HFS requested a lot of flexibilities from the federal government and has also moved forward with some that they don't need permission from the government to do. If you haven't already been to these websites, please know that the state is really working hard to try to be as transparent as possible. With regard to Medicaid, a lot of the notices that have gone out are really geared towards the medical providers. There are a couple for like assisters, and then there's a couple for clients about applying during this time, but it's all available for the web on their website. Some of the changes that they've already implemented, right now they are allowing self-attestation on applications for Medicaid only. SNAP is handled differently, so it's part of the confusion with all of this, but basically they will accept the client's word about income and different things during this COVID emergency time. I still err on the side, if you can submit the proofs, do so, but just know that they are accepting self-attestation for most cases at this point. They've also stopped terminating Medicaid right now, and that goes for even all kids, folks who are turning 19, they've suspended all terminations. The only time cases should be closed during this public health emergency is if the client requests it, or the client dies, or the client moves out of state. That also means redeterminations should not be happening right now, though you will see some clients probably still getting some notices, especially those that can be electronically verified. They may still continue, but everything's kind of been delayed. And then they've also implemented adult presumptive eligibility, which I will talk about in a moment. So I kind of already said this, but basically they're accepting self-attestation for all of these things. But if you're helping the client apply for other benefits, still need to provide those proofs. And I already mentioned this about cancellation and re-Ds. Sorry, I forgot I had this level of detail in here. But yeah, so the whole idea behind some of these flexibilities is just knowing that, you know, COVID-19 has been impacting so many. We want to keep people covered if we can. Adult presumptive eligibility. Those of you who are familiar with the Medicaid presumptive eligibility for pregnant women, this is a little different, but essentially what they're doing is they're looking at the applications, and they even applied presumptive eligibility, or should have been applying it, to the backlog of applications. And so they're using the information submitted on the application to get coverage started right away, while then they continue to process the full application. Right now it's for adults between 19 and 64, so really your ACA adult and your family care population. At this time there is not adult presumptive eligibility for the aged, blind, or disabled population. And as you can see, there's some other requirements too. They don't get an HFS medical card, but the provider should be able to see that it's there so that they can start getting care. I think, yeah, I think one of the challenging things is going to be this. So in the grand scheme of things, the state of Illinois is committed to covering testing and treatment for COVID-19. They've made that very clear, regardless of insurance status, and we presume that to mean regardless of immigration status as well. The challenge is behind the scenes, because providers want to get paid, right? And patients need the care, and it doesn't all line up at the same time. And it's not really up to us as assisters or other interested advocates to really understand all of that. But I would say if you start seeing someone getting bills from providers for COVID-19 related things, please reach out on Help Hub and let's find out if there was something that maybe the provider could take access of. Because as I already mentioned, you know, emergency Medicaid for people who fall within those income guidelines is available for COVID-19 as well. The testing has been pretty much, you know, I'm not as up to speed on that, but there's obviously a lot of community sites out there where people can get tested for free. And then in addition, on the provider side of things, HRSA, or the Healthcare Resources and Services Administration, has a fund of money also to help cover treatment. And that would be especially critical for people who are maybe over income for the emergency Medicaid. But we just know that there's a lot of questions even on the provider side of things, and I've like barely scraped the surface with other advocates who are much more well versed in it than I. And so again, the takeaway is please, if you start seeing people getting bills for COVID, reach out on Help Hub. You can also email me directly, but I'll probably loop in like Stephanie Altman from Shriver or Carrie Chapman from Legal Counsel, who are much more ingrained on that side of things. Anyway, so for whatever reason, the feds still haven't necessarily approved the 1115 waiver request, which was going to expand COVID-19 testing and treatment regardless of insurance, regardless of income, including even for people who have insurance but maybe had a really high deductible. So just know that those are some of the things that they are still waiting on, and there's some really helpful fact sheets on their website. They have, my understanding is they were supposed to already start waiving the premiums and copays for all kids and health benefits for workers with disabilities, that didn't necessarily need permission from the federal government first, but these are just some of the flexibilities that they requested. In addition, providers had some extra flexibilities, things like suspending prior authorizations, and we've heard a lot about telehealth. Again, more information available on the website. And just kind of circling back again and summarizing, you know, what does that mean coverage for undocumented for COVID-19? Obviously continuing to access community health centers, charity care, already talked about emergency Medicaid. And I also just want to reassure that when it comes to public charge concerns, they have very clearly stated that COVID-19 related care is not subject to public charge. And emergency Medicaid is already one of those programs not subject to public charge anyway. With the ACA, with the marketplace, we were hoping that the federal government would open up a special enrollment during this emergency period, but no, that has not happened. However, if someone did lose a job and lost health coverage for that reason, they could then get a special enrollment period if they're over income for Medicaid. And that was a whirlwind around Medicaid and COVID-19, I know. So I see at least one more question has come through. Yes, thank you, Rachel. So referring to SNAP. So I only included the COVID-19 updates today about Medicaid, which I know is somewhat general. I'd be happy, if there's time, we can try to talk about this in a little more detail, because there's all sorts of things with SNAP that have happened. But I would also point you to the DuPage Federation website. We have an ongoing Google Doc. Now, it's been a couple weeks since I've updated it significantly. I'll probably be revisiting it next week, actually, because a couple things are coming to an end. But we have done our best to try to compile a lot of these changes with SNAP and other programs. So I would point you there to our website and look for the COVID-19 site. There are some other agencies that have also put together some COVID resources. But to answer your question quick, yes, SNAP, for anyone who is set to expire or renew their SNAP benefits in definitely April, May, and June, and I can't remember now, I think March too, they were extended for 6 months. The Medicaid isn't necessary. I guess you could say it's, I don't know if I would use the term you did automatically renewed. I guess what it is it's just not ending, and they're not doing redees right now for Medicaid. So as I said, they're not terminating cases, so people should continue. And HFS does not have a plan yet for kind of when they'll reestablish that Medicaid redetermination process. They figure once the emergency is officially declared over, then they will work with the federal CMS to kind of bring redetermination back on board. So as we have more information, we will try to share that. So, what other questions? I know it's right about noon right now. So are there other questions that folks have about anything? You are always welcome to email me individually. These are our agenda items for July 9th. I will probably speed through the information about ABE and manage my case, just because I know that spend down and dual eligible, that'll take a little bit of time. And now I kind of have a feel for breaking up the content. So, all right. So thank you so much for attending this morning's session. I hope you all are able to take advantage of a long weekend. If anyone's taking more extended time off, enjoy that, and I hope you all are well. And I will stay on for a few minutes if there's individual questions, and we'll go from there. So thanks again, everyone. I'll stay on maybe for about 2 or 3 more minutes.